Uh, so hi everyone, my name is Conrad. I'm one of the new neurologists at Scarborough Health Network. So I just recently started on the inpatient neurology service at the beginning of January. And I'm looking forward to meeting a lot of you there. I also do or report on the EEGs at the hospital and do some EMG studies. So today I thought I would start off with a case, um, mostly just to go through some new kind of guidelines and treatment updates about the condition. So I'll just start off then. So this is a patient that I saw in the neuromuscular clinic. She is a 54-year-old right-handed female who presented with 2 to 3 year history of weakness in her arms and legs. This was slowly progressive, and she had difficulty with kind of over the head movements with her arms and getting out of low-lying chairs or climbing stairs with her legs. She also felt this heaviness in her legs during ambulation. She didn't have any bulbar or respiratory symptoms, no cramps or fasciculations. She didn't have any fluctuations to suggest something like myasthenia gravis. And importantly, she didn't have any sensory symptoms, no other neurological symptoms, and no systemic or constitutional symptoms either. No rash, joint aches, pains, or sicca symptoms or oral ulcers. So she had a past medical history of hypothyroidism, and she was previously on medications. However, she was someone who, had not seen her family doctor for many years, and so had never refilled her prescription. She had no known drug allergies. She had no history of any kind of nerve or muscle problem in her family. And she worked in insurance. She's from Vienna. She doesn't smoke, no recreational drug use, and she had occasional alcohol use. So on general inspection, she was well appearing. There weren't any rash or swollen joints noted on her exam. She was alert and oriented, and her speech was fluent. Her cranial nerve examination was normal. She had normal bulk and tone in the arms and legs, and her reflexes were normal. The most prominent thing on her examination was that she had this diffuse weakness in her arms and maybe more proximal greater than distal weakness in her legs. In addition, she had some neck flexion weakness and neck extension weakness as well. The rest of her neurological examination, sensory and coordination exam were normal. So in the EMG lab, I performed nerve conduction study testing on her, which was normal. She also had an EMG, and most of the units in her EMG in weak muscles were of short duration and small amplitude, polyphasic and early recruitment, which typically indicates a myopathic process. In addition, there were fibrillation potentials present, which is something that correlates pathologically with muscle fiber necrosis, vacuolization, and fiber type splitting. So in essence, she had some form of a generalized myopathy with fibrillation potential, so an irritative myopathy. So I sent her off for some labs, and her kind of metabolic workup for acquired causes of myopathy were mostly normal, with normal CBC lights and extended lights. She did have a low vitamin D level, and her TSH was elevated, probably around 8 to 9. So certainly vitamin D deficiency and hypothyroidism are both things that can cause myopathy, but normally on the EMG, the units could look normal, or they could have some myopathic features to it, but certainly fibrillation potentials would be something that's atypical. So while vitamin D deficiency and hypothyroidism might have been contributing to her weakness, it certainly wasn't the driving cause. Her CK level marker of muscle injury or damage was elevated at 549, and she was ANA positive. her inflammatory myositis antibody panel came back, negative for any of the myositis-specific antibodies, but she was strongly positive for anti-Rho and anti-La. As I mentioned before, she didn't have any, major Zika symptoms, and the rest of her inflammatory workup was negative. So ultimately, I sent her for a muscle biopsy, which is kind of the gold standard for diagnosis. I picked the left biceps, and her biopsy was compatible with immune-mediated myositis, consistent with dermatomyositis. So patients with dermatomyositis, as you guys probably already know, can be associated with interstitial lung disease as well as malignancy. So I sent her for CT chest abdo-pelvis. She did have some features of interstitial lung disease on her CT chest, but there was no evidence of malignancy on her abdo-pelvis CT. So dermatomyositis is an autoimmune condition that can affect many different organ systems, mostly affecting the muscle and skin, but it can affect the lungs, cardiac system, as well as GI system as well. It typically affects both adults and children in a bimodal distribution, affecting women more than men. And the incidence is around 1.2 to 19 per million persons per year, so a relatively rare condition. In terms of the clinical features, so patients can present with a myopathy, so limb girdle pattern of weakness, worse in the proximal legs than arms. And patients can additionally have troubles with swallowing, as well as neck flexor greater than neck extensor weakness. They can have a very characteristic rash, which I'll describe in a little bit more detail in the next slide. But in terms of pulmonary function, they can have interstitial lung disease. Cardiac-wise, they can have conduction defects or kind of wall motion abnormalities. And in the GI system, they could have delayed gastric emptying, thought to be related to the involvement of kind of smooth or skeletal muscle within the GI tract, or vasculopathy. As there's some pathological evidence that perhaps the inflammatory infiltrates can affect the endothelial cells of small blood vessels, and so that can increase your risk of kind of having this hemorrhage within the GI system. In addition, patients can have a malignancy in around up to 45% of the time. And patients who, with a new onset features of dermatomyositis, might present with their cancers maybe 2 or 3 years after the initial diagnosis. And so previously, there weren't any guidelines regarding to how cancer screening should be done in these patients with dermatomyositis or how frequently. And so one of the studies I will be talking about later will be some new guidelines regarding how to perform malignancy screening in these patients. And it was published maybe like 2 to 3 months ago. In terms of the rash that can occur in patients with dermato, so they can have this kind of very violaceous purple rash located over the extensor surfaces of the small joints of the hands called Gottron's papules, or on the elbows or knees called Gottron's sign. And they could develop this heliotrope rash, which can be associated with some periorbital edema. In addition, they can have a rash in sun-sensitive areas like the V-neck sign and the shawl sign. Calcinosis is something else that can happen in the skin, which more frequently happens in juvenile patients with dermato rather than adults. In terms of the investigation, so initial labs will involve looking for kind of markers of muscle injury or damage, such as an elevated CK level. There are some other markers as well, including AST, ALT, LDH, and aldolase. The CK levels can be elevated in dermato around 90% of the time. Patients can also be ANA positive up to 60% of the time, but most frequently, those patients have more of an overlap myositis as opposed to, which can have features of dermatomyositis. And then oftentimes, a myositis antibody panel will be sent for myositis-specific and associated antibodies. The ones that are specific to dermatomyositis are listed here, and each of these antibodies can have different variations in terms of their kind of phenotypic profile, prognosis, as well as risk for malignancy. For example, TIF1 gamma and NXP2 have a higher risk for malignancy as compared to the other antibodies. In this group here, the overlap myositis group, some patients can have something called the anti-synthetase syndrome, which consists of an inflammatory myopathy, interstitial lung disease, mechanics hands, as well as arthritis. That's one condition that can be also associated with myositis, as well as a lot of other rheumatological conditions can have features of myositis as well. And most frequently, the phenotype and the biopsy findings resemble that of dermatomyositis. There are some other inflammatory myopathies, including inclusion body myositis and immune-mediated necrotizing myopathy with these antibodies listed here. So in terms of the muscle biopsy, so in terms of muscle selection, this is typically done in a weak muscle, probably around like 4 to 4 minus on the MRC grade scale. When choosing a muscle, it's important not to choose something that's a little too weak, because you might end up just getting end stage muscle on biopsies, which is just going to be necrotic and fibrotic tissue without any capability of making a clear pathological diagnosis. In terms of the features for dermatomyositis, you can see here the main definite pathological feature for dermato would be for this perifascicular atrophy. So this is a muscle fascicle with all the individual muscle fibers. And along the edge of the fascicle, you can see atrophy of the muscle fibers here. And there are some infiltrates, like inflammatory infiltrates here, mostly consisting of CD4 T cells as well as B cells. As I mentioned earlier, there can be some deposition of inflammatory infiltrates, such as MAC complex deposition within the endothelial walls, which can form these things called pipestem capillaries. And additionally, when staining for MHC1, you can see that there's kind of this inflammation locating over the perifascicular area, so right at the edge of the muscle fascicles. So in terms of treatments, initially patients might be started on high-dose steroids. They can be pulsed, or they can just be given kind of a high oral dose of steroids, so normally around like 1 milligram per kilogram. The steroid-sparing agents such as azathioprine, methotrexate, or MMF can be started concurrently with the steroids, especially if patients have particularly severe weakness or other symptoms. But patients can also just be put on steroids and then eventually weaned. And then the other indication for starting a steroid-sparing agent would be if, for example, they were unable to kind of completely come off steroids, or they remain symptomatic while on treatment. For those patients who are treatment refractory, many of you might have used IVIG, for example, on an inpatient setting, or rituximab on an outpatient setting. IVIG had been previously used based off of some evidence of small prospective trials and one very small randomized control trial. But recently, in 2022, they did a more larger double-blinded randomized controlled trial published in the New England Journal of Medicine, which I'll be going through at the end of this talk as well. Just to start off with, I'm going to be discussing the new guidelines that was published about 3 months ago regarding malignancy screening in these patients with dermatomyositis. So there were kind of two parts to this paper. The initial part was looking at a meta-analysis of all the main risk factors for developing malignancy in patients with inflammatory myopathies. They also did a systematic review of all of the kind of main investigations that were found useful in identifying malignancy in these patients. And then the second part of the study revolved kind of an expert opinion from this group called the IMAX group. So it was a group of neurologists, rheumatologists, and other specialists who see patients with dermatomyositis frequently, and they came together to come up with kind of clear guidelines for clinicians to use when cancer screening these patients. In terms of the main risk factors noted, so these are the high risk factors are listed here. One of the main high risk factors noted was having a dermatomyositis, which has a higher relative risk ratio of around 2.2 for having a malignancy as compared to the other inflammatory myopathies listed here. So these are like the overlap myopathies, overlap myositis, and the kind of the necrotizing immune-mediated myopathies, polymyositis, and the dermatomyositis in the absence of any weakness. So other risk factors, as I previously mentioned, are associated with some of the antibodies like TIF1 gamma and NXP2. Age over 40 was deemed a high-risk factor, mostly based off of some epidemiology studies looking at patients with these high-risk antibodies. And it just so happened that in that paper, the youngest patient with cancer was around 40, so they just put a cutoff there. Other high-risk factors include high disease activity, even though patients are on optimal therapy, having troubles with swallowing, so dysphagia, or cutaneous necrosis. So these are some of the intermediate risk factors, so some of the other antibodies that I previously discussed. And low risk factors include kind of antibodies associated with the overlap myositis, as well as some of the aminoacyl tRNA synthetase antibodies, which can cause the antisynthetase syndrome, which I mentioned earlier as well. So after these risk factors were determined, they then kind of stratified each of these patients with immune-mediated myopathy into a high, moderate, or low risk of developing cancer. So for the high-risk patients, they required kind of more screening, obviously, than those with low risk. What they proposed is along with kind of age-appropriate cancer screening, patients should have both this basic screening panel and enhanced screening panel for malignancy screening. So the basic screening panel involved just doing a very comprehensive history and physical exam. Because if anybody had any kind of clinical signs or symptoms of malignancy, such as systemic symptoms, weight loss, etc., they would be screened more thoroughly. They suggested to do, a serum protein electrophoresis, which assess for paraprotein or for hematological malignancies, a chest X-ray to look for lung cancer, and ESR-CRP for some inflammatory markers, which might be elevated in malignancy as well. For the more enhanced screening panel, beyond just simply doing the CT kind of chest, abdo, pelvis, they also suggested doing a CT scan of the neck. As patients with nasopharyngeal cancer, there is an association with dermatomyositis. They also suggested some kind of sex-specific malignancy screening, including testing for PSA and CA-125, and as well as doing cervical screening, mammography, pelvic and transvaginal ultrasound, as well as a fecal occult blood for colorectal cancer. So in this high-risk group, if initially both the basic and enhanced screening panel were negative, they proposed perhaps doing some additional testing if the suspicion was still high for malignancy, which would have included things like endoscopy, colonoscopy, and even a nasoendoscopy for some areas where nasopharyngeal cancers were a little bit more common. So if no malignancy was determined at that stage upon diagnosis, then every year thereafter, they just suggested to do the basic screening panel for the high-risk patients. And I should mention that the high-risk patients were those that had two high-risk factors outlined in the prior table. So for the moderate risk patients who had just two intermediate or one high risk factor, they suggested just doing the basic and the enhanced screening profile, and then no screening for cancer upon follow-ups thereafter. And for the low risk group, just age appropriate cancer screening and then the basic screening panel. So in my patient that I discussed earlier, she certainly had features of dermatomyositis, so one high risk factor, which would already put her in the intermediate kind of risk, although she could potentially have had a more kind of overlap phenotype as well, which would put her kind of in between kind of a moderate to low risk. And so perhaps I should have completed it in a little bit more detail, a more enhanced screening panel to involve kind of CT scanning of the neck and also some of these other tests that are outlined here as well. So the second part of this talk, I was going to discuss this clinical trial that was published in October 2022. And so this was a larger double-blinded randomized control trial, IVIG versus placebo treatment in patients with dermatomyositis. So the patients that were included in this trial were mostly adults, and they could be on kind of steroids or immunosuppression during the study. Most of you probably know what IVIG is already, but just to summarize very briefly, it is a pooled immunoglobulins from healthy donors, and it can be helpful as an immunomodulatory and anti-inflammatory agent, and is very useful for many different types of autoimmune conditions, especially within the neuromuscular world. In terms of side effects, the main concerning side effect would be that of thromboembolic events. But there can be some infusion reactions as well listed here. So patients can have fever, fatigue, myalgia, chills at the initial stages of the infusion, as well as some allergic type reactions and renal failure. So in this study, patients were randomized either to the placebo or the IVIG arm, and then they were given IVIG every 4 weeks, and their main endpoint was measured at week 16. They were given 2 grams per kilogram, which is the typical dose we use. And then after week 16, they transitioned into an open label extension period where everyone received IVIG. Their main endpoint was something called the total improvement score. So it's kind of graded from 0 to 100, with 100 being the maximal amount of improvement demonstrated. And it was measured based off of kind of 6 core set measures, which are listed here. Some of which included things like the CK level, muscle weakness as determined by the MRC grade strength, as well as a lot of disease severity scales, which were kind of interpreted by both the patients or filled out by both the patients as well as from the physicians, caring for those patients. So their main endpoint at 16 weeks were those patients who reached a minimal level improvement, so around a score of 20. So this is a table of the total improvement score in the randomized and the open label extension phase. And you can see here that generally the patients who received IVIG had more improvement as compared to the placebo arm. And later on in the open label extension phase, the patients who were originally receiving placebo and then IVIG had kind of higher total improvement scores compared to placebo as well. Over here, this is just a graph summarizing kind of the time to improvement, or the time it took patients in the IVIG versus placebo arm to reach the minimal improvement of 20. So it's summarized over here that patients in the IVIG arm generally reached minimal improvement at around, on average, or mean average of around 35, and those in the placebo group around 115 days. So generally speaking, patients who were receiving IVIG had improvements faster than those in the placebo arm, obviously. In terms of the adverse events that were reported in the study, so many patients did have the headache and other kind of infusion type reactions, but there were 6 thromboembolic events in the IVIG arm among 5 patients. And this was thought to be related to the infusion rate that was used, because after they kind of slowed the infusion rate down, the incidence had decreased dramatically in terms of those type of events. So just to finish off by saying that in the patient that I saw, we initially started on steroids, and the patient, did have some treatment responsiveness, however, had a lot of side effects on the medication with a lot of weight gain and mood phases. So we did have to kind of wean her off the steroids, and then started her on a steroid-sparing agent. However, she wasn't still having kind of the full treatment effectiveness. So we recently started her on IVIG as well, and we'll plan to see her back in follow-up in maybe a month or 2 months' time. So that was it for me. Are there any questions at all?
Hey, Conrad.
Oh, hey, Dave.
I might have missed it in the trial. Were there any restrictions or limitations on other treatments? Like
No, so all patients were on steroids or 1 or 2 immunosuppressants during the trial.
and were they allowed to like adjust their other treatments at will during the trial, I imagine?
During the trial, they weren't, at least in the randomized phase, they weren't, they tried to keep all the treatments consistent to avoid any kind of
Right.
like biases. Yeah.
Okay. Thanks.
Well, okay, well, thank you everyone for attending the talk. If you have any other questions, you could always email me as well.